Hand and wrist patterns of injury. As you know, traumatic hand and wrist injuries account for a large proportion of the workload of all the emergency departments. So the purpose of my presentation will be to describe, first of all, the most common traumatic acute bone and soft tissue injuries of the hand and of the wrist. And I will pay special attention to the anatomy and to the mechanism of injury, since this is very important to recognize on imaging patterns of injury. So this is the outline. First, I will go to the wrist and I will describe the most common fractures of the distal radius, also carpal injuries, especially fractures of the scaphoid, carpal dislocations, also fractures and dislocation of the radius and the ulna, and also related to the acute soft tissue injuries, especially lesions of the scapholunate ligament. After, we will move to the hand, and I will explain something about the volar plate fractures, the mallet finger, the skis thumb, cross injuries, and also dislocations of the fingers. Fall on a palm is probably the most common mechanism of injury of many of the most common fractures and soft tissue injuries of the wrist and also of the forearm. This slide showed how the fall on a palm put the wrist in a hyperextension position, causing more of the most fractures of the wrist and of the carpus, especially in the extra-articular fracture of the distal radius, which is also called the Colles fracture, the intra-articular fracture of the distal radius, which is called Barton's fracture, and also distal to this, the fracture of the scaphoid. And why sometimes with the same mechanism of injury we have an isolated fracture of the distal radius, and why sometimes we can also have an associated fractures of other structures, especially the scaphoid, also sometimes carpal dislocations of a fracture of the scapholunate ligament. In an old lady, so they have a diminished bone density at the level of the distal radius, and sometimes due to this, the impaction of the fracture is stopped at the level of the distal radius, and there is no transmission of this from distal to this level. In young patients, sometimes the peak of the trauma is higher compared with patients with more age, and sometimes also the high density of the bone distal to the radius cause that the transmission of the force goes a bit further to the radius, causing an associated fractures of the distal structures, especially the scaphoid, scapholunate ligament, causing sometimes a carpal dislocation. So now we are going to move to the most frequent fracture of the distal radius, which is the Colles fracture. This is, per definition, an extra-articular fracture of the distal radius, where you can also see a dorsal angulation and posterior displacement of the distal fragment. And in many cases, but not always, there is also an associated fracture of the distal ulna. The mechanism of the injury is the mechanism I explained before, so fall on a palm with the wrist in hyperextension. Here, an example of a Colles fracture when we see the extra-articular fracture of the distal radius with the dorsal angulation of the distal fragment, and also in this particular case, also an associated fracture of the distal ulna. In the same way we have a Colles fracture, we can also have what we call the reverse Colles fracture, also called the Smith's fracture. In this particular case, we have also an extra-articular fracture of the distal radius, but in this case, there is a volar angulation of the distal fragment, and this is due to a different mechanism of injury. In this particular case, we don't have a fall on a palm, we have more a direct blow of the dorsum of the forearm, and also sometimes a falling onto the wrist when the wrist is flexed and not extended. Example of a Smith's fracture. Sometimes when the mechanism of the fall on a palm caused in a different way, we can also have what we call a dorsal Barton's fracture. In this particular case, there is a subluxation of the radiocarpal joint, causing also an intra-articular fracture marginal and the dorsum of the distal radius, and the combination of these features is what we call the dorsal Barton's fracture. In the same way, we also have a reverse Barton's fracture, which is also called the Volar Barton's fracture. In this case, we also have the intra-articular fracture, in this case at the volar part of the radius with the subluxation of the radiocarpal joint, and the mechanism is also different. The palm on a palm in this particular case is also blow to the back of the wrist rather than a fall on a palm. Sometimes the mechanism of fall on a palm doesn't cause a fracture of the distal radius. Sometimes it causes a fracture of the scaphoid. And why the scaphoid more than other of the bones of the carpus? This is explained for the anatomy of the scaphoid. The scaphoid is a bone which is located between the proximal and the distal carpal row. It's like the bridge between the proximal and the distal carpal row. There is also an important ligament going through the waist of the scaphoid, which is called the radioscaphoid capitate ligament. And when we fall on a palm, the hyperextension trauma at the level of the wrist put the waist of the scaphoid in a maximum of tension, and this is the place where we will have many of the fractures of the scaphoid. So, and why this bone is different compared with the other carpal bones in terms of complications? It is due to the blood supply of the scaphoid. As you know, the blood supply of the scaphoid is different, is unusual. It enters via the distal pole of the scaphoid, running through the scaphoid in the direction of the proximal pole of the scaphoid. So if we understand this, we can understand that when we have a fracture of the waist of the scaphoid that occurs in more or less 80% of the cases, we have a moderate risk to develop an avascular necrosis, more or less 30% of the cases. When we have a fracture of the proximal pole of the scaphoid, which occurs more or less in 20% of the cases, we have a high incidence for avascular necrosis of the scaphoid. And when we have a distal pole fracture, which occurs more or less in 5–10% of the cases, the chance that we have an avascular necrosis is quite low. So when we have the clinical suspicion of an scaphoid fracture and the conventional X-ray is negative, we have different methods just to try to help us in the diagnosis of an occult scaphoid fracture. First, we have the CT. As you know, the CT can identify some fractures, but there is, of course, an error rate. And the CT is not good enough to make the diagnosis on some trabecular bone injuries. The relevance of this is questionable. We have isotope bone scans. It's used in some hospitals, but I will not recommend to use it because it's very sensitive, but it's non-specific. After an acute event, in more than 35% of the cases, there is an increased uptake. It is due to other problems rather than a fracture of the scaphoid. So nowadays, I think the MRI is the investigation of choice just to make the diagnosis of an occult scaphoid fracture. Despite all the efforts to make the correct diagnosis of a scaphoid fracture, sometimes we also have fractures that they are not seen at first time, and we can also have some complications due to this situation. So one of the most important complications of the scaphoid fractures is the avascular necrosis. The idea is that if we try to find the avascular necrosis in an earlier stage, we can try to treat it or also in an earlier stage. Nowadays, I think the MRI with contrast enhancement, I think, is the method of choice for the diagnosis of the viability of the proximal pole of the scaphoid. Nevertheless, studies had conflicting results. The numbers in these studies have been always quite small, and there is really no robust evidence of improvement in the outcome as a result of this enhanced MRI. And there is one study that described that there is no outcome benefit in a group of patients who underwent MRI prior to the surgery. But now we have more sophisticated techniques like the dynamic contrast enhanced MRI. In this particular case that I took from one article, you see in the first image that the signal intensity of the proximal pole of the scaphoid is quite low, that we could think that it is referred to an avascular necrosis of the proximal pole. With the dynamic contrast enhanced MRI, we can evaluate that there is a good perfusion of the proximal pole of the scaphoid compared with the distal pole. In the next case, we have also a patient with a fracture of the waist of the scaphoid, with also some enhancement around this fracture line on the T1 FET set weighted images, and the dynamic contrast enhanced MRI showed that there is a poor perfusion of the proximal pole of the scaphoid compared with the distal pole. And how good is this dynamic contrast enhanced MRI to make the correct diagnosis of an avascular necrosis? I think in the articles I have been looking at, the opinions are a bit different. For example, in one article published in 2011 in Radiology by Donati and all, they tried to compare the dynamic contrast enhanced MRI with the normal MRI using as a gold standard the histopathological specimens of the proximal pole of the scaphoid, and they conclude that there is a poor correlation between what we see on the MRI and what we see on the histopathology in terms of healthy bone, necrotic bone, and also callus formation. Nevertheless, one article that has been published recently in Skeletal Radiology in 2013 showed that the dynamic contrast enhanced MRI has more accuracy compared with the normal MRI and the static contrast enhanced MRI. So the conclusion is that although this is maybe not perfect, it's the best tool we have so far for the diagnosis of an avascular necrosis. Other complications of a fracture of the scaphoid, like non-union and pseudarthrosis, can be picked by CT, and also other complications like the humpback deformity of the scaphoid due to the angulation of the scaphoid at the level of the fracture can be also assessed by CT on sagittal view. But when we have a fall on a palm, we just have a hyperextension of the wrist, but we also can have other problems at the level of the arm and at the level of the elbow. So the fall on a palm can also transmit some axial load through the bones of the forearm and also in the direction of the elbow. Just if we think that the elbow joint together with the radius and the ulna and also the distal radioulnar joint is like an elongated ring, we can understand that when we have a patient with a fall on a palm, the axial load can cause a fracture in one part of the ring, but we always have to look for an associated fracture at the other level of this ring. So this will explain how in, for example, the Monteggia fracture dislocation, we have an axial load. It occurs more on the proximal part of the ulna with an associated dislocation between the radius and the capitellum. We can also understand also in these cases how in the particular case of the Galeazzi fracture dislocation, when we have an axial load at the level of the radius, especially the distal radius, it can be an angulation at that level, and due to this, a dislocation of the distal radioulnar joint. And sometimes when also we have a fall on a palm, this axial load can impact directly at the level of the head of the radius, with also an associated fracture at the level of the membrane between the radius and the ulna, causing at the same time also a dislocation of the distal radioulnar joint. So in this case, I think the take-home point is when we make an X-ray and we see a dislocation of the radius and the ulna, of course it can be still an isolated dislocation of the radio-ulnar joint, but always try to think in associated fractures, like for example the fracture in the Galeazzi and Essex-Lopresti fracture dislocation. So these names are, in many cases, they are complicated, but if we try just to remember what's happening, if we remember that I was attacked by a mugger, so the mugger, so the fracture of the Monteggia is a fracture of the ulna, and the Galeazzi fracture is the fracture of the radius. This can also help us just to remember more these complicated names. I'm not going to explain in detail the extrinsic ligaments of the wrist, but I think it's important to know the most important ligaments at the dorsum of the wrist, and also the most important ligaments on the volar part of the wrist, because in this way we will be able also to understand the mechanism of injury of two particular fractures. So, regarding the extrinsic ligament of the wrist and the dorsal side, we have two main ligaments. This is the first ligament. This is the dorsal radiotriquetral ligament. The second ligament is the dorsal intercarpal ligament. And as you see here, the attachment of these two ligaments is at the dorsum of the triquetrum bone. So you can understand that when we have a twisting trauma of the wrist, it could be an avulsion fracture at the dorsum of the triquetrum, and this is the explanation for the dorsal tip of the triquetrum, which is the second most common fracture at the level of the carpus. It's seen on the lateral view as an avulsion fragment at the level of the triquetrum. Following, I will move now to the volar extrinsic ligament of the wrist. There are two main ligaments. The first is the radiolunotriquetral ligament, and the second is the radioscaphoid capitate ligament. And as you see here, the attachment of these two ligaments is at the level of the processus styloideus of the radius. So in this particular case, we can also have an avulsion fracture, isolated avulsion fracture of the processus styloideus of the radius, and this is also called the Chauffeurs Fracture. Now we are going to come back to the first slides I explained before, so the palm on a palm with a hyperextension trauma of the wrist. This is also the mechanism that explains many of the carpal dislocations of the wrist. They have been described 4 different stages based on the magnitude and the duration of the loading. Just to understand what's happening in these carpal dislocations, we also have to take and to have in our mind 2 different lines and arcs of the carpus. Just for this, we are going to forget for a while these Gillula lines that we know just for the assessment of the alignment of the carpus. I will describe 2 new lines. The first is the lesser arc, which is an arc which is surrounded the lunatum. And the second line is the greater arc, which is a line going through the waist of the scaphoid, capitate, amatum, triquetrum, and in some new classification also the distal radius and the distal ulna. The space in between the lesser and the greater arc, it is called the zone of vulnerability. So, the first stage of these perilunate instability patterns following the MAYFIELD classification is the scapholunate dislocation. So due to this hyperextension trauma of the wrist, we can have a rupture of the scapholunate ligament. In this particular case, we always have to look for associated fractures, especially fractures of the distal radius. And I think to understand why this ligament is more prone just for this kind of injuries than other ligaments of the wrist, we have to understand what's happening when we apply an axial load at the level of the proximal carpal row. So this is a scaphoid, this is lunate, and this is triquetrum bone. So when we apply this axial load, the scaphoid tries to flex to the volar part of the wrist, and the lunatum and the triquetral, they flex in the opposite way to the dorsum of the wrist. So if we understand this, we can understand that after the axial load, there is a maximum of stress at the level of the scapholunate ligament, and this is like a very tense spring which is ready to break. When we have this rupture of this scapholunate ligament, we can classify it in 3 different types: type 1, type 2, and type 3. The type 1 and type 2 are more the acute version of this scapholunate ligament, and the type 3 is the rupture of this ligament with associated arthrotic changes. So the type 1, we have a patient, they have fall on a palm, he has a lot of pain on the wrist, and we make an X-ray. In this particular case, the X-ray is normal. So although the patient has a rupture of the scapholunate ligament, there is no abnormality on the static X-rays. In these cases, we have just to perform dynamic examination, sometimes with maximal ulnar or radial deviation, just to try to identify the lesion of the scapholunate ligament, sometimes also MRI examinations. And in my particular opinion, the fluoroscopic diagnosis is very important for the diagnosis of this type 1 scapholunate dissociation. The type 2 is easy to see because we make an X-ray, the patient has the perfect clinical picture with the pain, the Watson test is positive, and we make the X-ray, and on the AP view, we see that the space between the lunatum and the scaphoid is bigger than normal, it's more than 3 millimeters. We also make the X-ray, the lateral view, and you can see a DC stand of the lunatum, so in this case, I think all is fitting in our diagnosis. Is it always a space between the scaphoid and the lunatum bigger than 3 millimeters abnormal? I will say no. We have just to correlate with the clinical presentation of the patient, the clinical pictures, because sometimes some patients they can have a quite lax scapholunate ligament where the space is a bit bigger than normal, more than 3 millimeters, but with the dynamic examination, the movement of the bones of the proximal carpal row remains normal, and in this case we are not in front of scapholunate dissociation. So the space always correlates in the proper clinical picture. In the type 3 of the scapholunate dissociations, so we have a patient that came to the emergency department due to a fall on a palm. He had a problem, he had pain at that level, and we performed the conventional X-ray. We didn't see anything. That the patient would send it home with the diagnosis of a contusion of the wrist. This patient comes after a couple of years with persistent pain and swelling at the level of the wrist. And in this case, we perform an X-ray and we see associated arthrotic changes due to the scapholunate dissociation that was missed at the first time. So this ligament was broken, but we didn't see it, and the patient is now in our emergency department with a lot of pain, and this is due to secondary arthrotic changes. We will call this problem a slack wrist. It's a scapholunate advanced collapse. What's happening when we have this rupture of the scapholunate ligament, and if we don't make the diagnosis at the proper time, there is with the time, a luxation and a migration of the scaphoid in the direction of the processus styloideus of the radius, causing some arthrotic changes at this level. With the time, there is also an approximation and a proximal migration of the capitate in the direction of the proximal carpal row. And with the time, we will also have arthrotic changes between the proximal and the distal carpal row, and the result of this picture is what we call the slack wrist, scapholunate advanced collapse. Now we move again to the stage 2 of the perilunate instability pattern. In this case, there is also a rupture of the capitolunate articulation, and in this particular case, we also have to look for associated fractures along the greater arc we explained before, especially fractures at the level of the scaphoid and fractures at the level of the processus styloideus of the ulna. On X-ray, we have a lateral view, and in the cases of the perilunate dissociation, we have a good alignment between the radius and the lunatum, but the distal carpal row is dorsal compared with the proximal carpal row and the radius. On the AP view, look always for associated fractures along this greater arc. Like in this particular case, there is a fracture of the waist of the scaphoid. There is a consensus to try to describe better these fractures and fractures dislocations. So first we have to describe the fracture, and after we will describe the dislocation. So in this particular case, we are leading with a trans-scaphoid perilunate dislocation. In the stage 3 of the perilunate instability pattern, there is an associated lesion of the lunotriquetral articulation. It is, the whole picture is called the midcarpal dislocation. On the conventional X-ray, on the AP view, we have more like a triangular-shaped configuration of the lunate bone, and on the lateral view, we don't have a good alignment between the radius and the proximal or the distal carpal row. This is the mid-carpal dislocation, so stage 3 of the perilunate instability pattern of the wrist. The last stage is the stage 4, which is the most severe perilunate instability patterns of the wrist, which is also called this is the lunate dislocation. In this particular case, almost all the articulations and the ligaments of the wrist are broken, and we have a lesion around the lesser arc of the wrist. And on the conventional X-ray, on the AP view, we will see again this triangular-shaped morphology of the lunate bone. And on the lateral view, there is a good alignment between the radius and the distal carpal row, but there is a palmar dislocation of the lunate bone compared with the other structures. So this is the lunate dislocation, the most severe stage of the perilunate instability pattern of the wrist. Now we will move to the hand. Just a couple of things. The volar plate fracture, as you know, is due to the hyperextension injury at the level of the PIP joint. Important to remember that sometimes there is an avulsion fracture that can be very small. It can be difficult to diagnose on conventional X-ray. So always try to perform a true lateral in order just to make the correct diagnosis with associated avulsion fractures, like in this particular case, because they can be very small. The mallet finger, the mechanism of injury is the sudden forced flexion of an extender finger, which is also called the baseball finger. We have 3 different types. In the type 1, we have the mallet finger with the classical deformity of the distal interphalangeal articulation, and we always have to perform a conventional X-ray in order to evaluate associated avulsion fractures. It is important just to make it, because if the fracture takes more than 30% of the articular surface, these patients are candidates for surgery. Now, the gamekeeper's thumb of the ski's thumb. The ski's thumb is the second most common injury of the ligaments in a skier after the strain of the medial collateral ligament. It is due to a forced abduction of forced valgus stress at the level of the NCP joint. The rupture of this ligament can be partial or total, and it's important to make the correct diagnosis if it's partial or total. I will say that in the first week after the trauma, we will go more for ultrasound. I will start with ultrasound. After 1 week, I think the MRI gives you more chance to make the correct diagnosis. So sometimes it is easy because we perform a conventional X-ray and we see, like in this particular case, an avulsion fracture at the level of the attachment of the ulnar collateral ligament, but sometimes can be very difficult, and we have just to go for more sophisticated methods of diagnosis like ultrasound or MRI. Extender lesion, you know, that is something that we also have to take into account to make the correct diagnosis. When we have a complete rupture of the ulnar collateral ligament, this ligament can be retracted and lies superficial to the aponeurosis of the adductor muscle, and in this particular case, this patient should go to the surgery in order to repair this damage. Crash injuries, heavy industrial machinery, sometimes the soft tissue injuries are or most important compared with the fractures, like in this particular case. And just to finish, I will say a couple of things about the dislocations of the fingers. They are caused by a forced hyperextension of the articulations, and this is the most common dislocation of the body. Like in the case of the mallet finger, important just to measure the size of the fracture, if this is present on the X-ray, because if the fracture takes more than 40% of the articular surface, this is called an unstable fracture. Dislocation of the fingers. So the take-home points is that I think it's very important to know the anatomy and the mechanism of injury of the most common fractures of the wrist and of the hand, because if we know this, we can evaluate special patterns of injury at the level of the wrist. And many of the most common soft tissue and bone tumors of the wrist, they have a common mechanism of injury, which is the fall on a palm, so try to look always for associated fractures. Thank you.